I'm Dr. Allan Perel, and this is Conversations in Medicine. This is Conversations in Medicine, and I'm Dr. Allan Perel, your host. It's my pleasure to bring in our guest tonight with regard to the topic of infectious disease. This program brings out cutting-edge issues to both the Staten Island and New York City and tri-state area community. So without further ado, I'm going to introduce our wonderful guest. This is Dr. Jessie Saverimuttu. She's an MD and a PhD. She's an attending physician at Richmond University Medical Center, and she works very closely with me in the Infectious Disease Department of Richmond University Medical Center. Welcome.
Thank you.
And Dr. Adreana DeMarinis. She's a senior resident in internal medicine, and a resident means that you're in training, you're an MD, you're a physician, and you're in your third year,
Correct.
Which is your last year of training. Congratulations. And we're going to learn a lot about infectious disease. Yeah. Infections are always scary to people, and they go from anything that's very benign, like a cut on your hand, and people are always worried about infections, catching infections from people who have a cold or coughing. And infections are very broad. There are bacteria, viruses, fungi, which are kinds of yeast infection or mold infection. There's a lot of different kinds of infection. So how do you become a specialist in infectious disease? What do you have to do, Dr. Jessie?
Yeah, that's an interesting question. Anyone can be an infectious disease specialist, but particularly after you're trained in your residency for 3 years, then you go into the infectious disease specialty and do a fellowship in that. And once you finish that, you become an infectious disease specialist. There are a few smaller boards which you can take and be more specialized. For instance, if you want to specialize in HIV, there is a specialist exam for that as well.
So AIDS or HIV, so there's a whole specialty with regard to that.
Yes. So you can specialize, mostly it's like an online exam, but you have to do the course, you have to fill in your CMEs, and then you sit an open book exam, and then you get the qualification if you pass.
And we'll go to Adreana. You work in the hospital now.
Correct.
And maybe next year, after you might be out in the community or do other things. I don't know what your ultimate goals are. But the idea in the hospital, we are very concerned about infections.
Yes. So first and foremost, we always advocate, hand washing hygiene. As simple as when you go see your patients, ensure that you either use a hand sanitizer, which we have them throughout the hospitals, also hand washing. And infections are very scary for both us physicians and as well as patients. And we try to do our best at Richmond University Medical Center to minimize infections by, as I said, something as simple as hand washing and, performing safety measures when we're placing central lines, which is a line that would, go through the neck region, or any type of procedures. It's always under a sterile field.
So Dr. Jessie, at the hospital, we're going to get to the community in a few seconds.
Yes.
But at the hospital, you're in charge and doing a lot of this work with infectious disease. How do we prevent infections?
Yeah, I have to tell you something. The moment I walk into a patient's room and I say, I'm Dr. Jessie, I'm an infectious disease doctor, everybody gets scared. They say, what infection do I have? Do I have Ebola? They all think of exotic infections. But infections are the simple ones that we see over and over again. So if you come into the hospital, the commonest infections that we would see are pneumonia,
which is an infection of the lung.
A urinary tract infection of the skin, which is called cellulitis. Diabetics, a lot of them have ulcers, which turn bad and hit the bone. They get bone infection called osteomyelitis. These are the commonest infections that you would see over and over again in the hospital setting.
Tell me about the different kinds of patients. I think, in essence, interesting enough, if a 20-year-old comes in with shortness of breath, a little fever, and has pneumonia,
Yes.
Usually they'll come to go to their primary care physician and they'll get some antibiotics and go home, usually.
Correct.
And we call that community acquired. It occurred outside.
Yes.
If somebody is sick in the hospital or an older patient, a lot of times they'll go into the hospital, and as we know, a lot of patients will actually die from pneumonia.
Correct.
So tell me what the difference is. Is it a different strain of pneumonia, or is it a different person who's getting it?
Yes. So if you think of a person in the community who has never been exposed to healthcare, that person would be exposed only to the bacteria that are in the community. These bacteria will not have been, the bacteria, not the people, would not have been usually exposed to antibiotics. So they will not show resistance, the bacteria won't show resistance, and simple antibiotics are going to work for them. If the person is young, it's better, because unless they have conditions where their immunity is very low, they would be able to fight it on their own, and help with the antibiotics should get them better very quickly. But if you think of the older persons, their immunity is already weakened as age goes by, and to make it worse, they have other medical problems, like diabetes is a very common thing. They can have heart problems, some of them have asthma, COPD. It actually makes them more prone to lung infections. When these patients come into the hospital, they are very vulnerable. They're coming in with a problem. They don't just walk in because they love the hospitals, they're coming in because of a problem. And when they come into the hospital with already a weakened immune system, the bacteria that are in the hospital or in a healthcare, even a nursing home, these bacteria are already exposed to a lot of antibiotics, and the bacteria start, producing resistant strains. And once they start producing resistant strains, these resistant strains now infect the patients who are already weakened. And those are very difficult to treat, because we need to have more and more potent antibiotics. So along with the fact that they have virulent bacteria and their own weakened state, they succumb. Quite a lot of them will succumb.
So it's more resistant. So
Yes.
what about cleaning up? So if somebody comes in with their little Lysol wipes, does that help the situation with bacteria in the hospital? Or is it just because there are sick people there, so people are sick and
Correct.
they've been on antibiotics,
Yeah.
and it's harder to fight it?
Every room should be cleaned, but there are certain conditions where it has to be like terminally cleaned. Like for instance, Clostridioides, now they call it not Clostridium anymore, they call it Clostridioides
Which is a bacteria.
difficile, which is a bacteria in the gut, and that causes severe diarrhea, and many patients can succumb to it. That bacteria produces spores. So even if you just clean it, you wipe it down, the spores can remain anywhere. In the ceiling, it can remain anywhere. So that room has to be terminally cleaned, and they use ultraviolet rays usually to clean those rooms. So once a patient leaves, you've got to clean that room. There are certain types of bacteria that produce resistance to almost all antibiotics. So those kinds of bacteria are extremely dangerous, because if lots of patients start getting that kind of bacteria, it's going to be like an epidemic in the hospital itself. So those rooms also have to be cleaned, like terminally cleaned. So beyond that, there is also something a little more recent, is one of the fungi, which is Candida, which is a normal Candida.
That's
but
an
it's
orange
not,
juice all over the place.
Yes, it's called Candida auris, and that's kind of becoming a bit dangerous, because it actually is resistant to almost all the antifungal agents that we have.
That's a more rare type of
It's a
Candida,
rare
yes.
type of, so it's not simple. Bacteria definitely keep on mutating themselves to produce resistance, and in the end we might run out of antibiotics.
Understood. So Adreana, in your clinic, and you also have an outpatient clinic, we will
Correct.
deal with patients in the hospital and patients on the outpatient side. Sometimes someone gets sick. Now, I think it would be very difficult for every physician, every healthcare professional to get a call every time someone has a low-grade temperature and a runny nose. We don't mind getting calls. We don't mind having patients come in. What's your threshold? What do you tell your patients, especially this time of year? We're talking about the winter, spring. What happens what would make them want? What would make you want to see them? What are the things
Sure.
that concern you?
Yeah, so our major concern would be, a patient, for example, who has elevated temperatures. When we say elevated temperatures, a 99 is a low-grade temperature. Someone who's spiking a temperature over over 101 or even 100, but yet has shortness of breath, that's very concerning. If they have a new onset of cough and they're producing sputum that is yellow in coloration, or if they feel that every time they walk and they really can't get out of bed and their energy level is very low, or they lost their appetite to eat, that would be a concern for us. If they can't carry on their daily activities, it's a concern that it's something more than just a maybe simple viral infection, which is an upper respiratory tract infection, which any of us could suffer from essentially, which you may have something called, doc, I have the sniffles, I have a low-grade temperature of 99. We monitor the patients, call them the next day and say, how are you feeling today? If their symptoms resolve, it was most likely a viral infection. If not, then I would be concerned that there's something else brewing, more of a bacterial infection that may need antibiotics to help the patient.
So let's go to a different part. Antibiotics.
Yes.
Now, everybody, we have children in college, and if I don't get a call once a week that half the dormitory or the fraternity,
Yes.
everyone's sick.
Mm-hmm.
And you get a call and saying, I'd like to be on antibiotics. And we have a debate. And I ask, is everyone sick in your place? And if they say yes, everyone is sick, I said, you don't need antibiotics.
That's right.
And so tell us a little bit about viruses and how they're spread.
Yes.
And bacteria, how they're spread. And the fear of people, whether they should be on antibiotics or are we using them too much?
Yes. In fact, that's a very good question, and antibiotic stewardship comes in here. It ties up with what I said earlier about resistance. The more antibiotics we use, the more we are going to lose them. So in college settings, they are all together, they get a virus, they feel feverish, they might even really have the fever, a sore throat, runny nose. All that is usually virus. So at the start of it itself, if someone is going to ask you, give me an antibiotic, it should be a no. They should recover on their own if they take good care of themselves, eat nutritious food, don't expose themselves in the cold, and do anything crazy. But if that infection persists for more than 3 days and they're getting sicker, they're getting high fevers, they're getting chills, now they're getting a cough and they're producing yellow or green sputum, then that means that viral infection has now moved into a secondary bacterial infection, which then would require antibiotics.
So you can have both. So it's not. So you can have one, and it makes because you're coughing, because your immune system is a little bit weaker, you can actually get a bacteria on top of it.
So yes, that's correct. So when that happens, you take the antibiotic, but not until then. Most of the time, they will recover on their own.
I mean, you say take the antibiotic, we mean go to the doctor.
Go to the
healthcare
doctor, don't
professional.
take it yourself. Yes.
You can't find it, your mom's or your sister's antibiotic that happens to be in the drug cabinet.
Don't do that.
Don't do that.
No.
We want to use the right antibiotic. So when we talk about right antibiotic, sometimes we do cultures. Maybe Adreana, tell me a little bit about it. If someone comes to your clinic and you think they might have the flu, they have high fever, they have body aches, they really feel very badly, and then, especially if it's in the winter season. And the flu season is much longer than we think. It actually goes anywhere from, say, September, October, all the way till what,
May.
April,
April,
May.
Mm-hmm.
So tell me, could you tell someone has the flu through a blood test, through a swab? How do we figure this out?
Yeah, that's a great question for the community to also know. So when someone has a chief complaint of chills and just fatigue and lack of appetite and loss of energy, we could do a nasal swab, which is very accurate in determining if a flu is present or not. Maybe they're not the most comfortable, but it's very quick, very easy. It looks like a Q-tip almost, and we just swab the nose region and we send it off to the lab. Another example, if someone comes in with a sore throat and we want to rule out strep throat, which it's very predominant among little children who get treated for it, but as we age too, we have to ensure that we treat strep throat because it could affect potentially the heart or the kidneys and needs to be treated, and we do a throat swab and we send that off to the lab. And when we culture something, we see how sensitive and or resistant certain bacteria are to certain medications, which are important and will help guide infectious disease doctors and myself in primary care of the proper antibiotics, so we don't overuse an antibiotic and grow resistance to the most common bacteria that's most prevalent in the community.
So when you send a culture to the lab, they'll tell you what the bacteria is. They'll put it in a little petri dish.
Yes.
And they could then tell which antibiotics it's sensitive to.
Yeah.
Yes.
So we could use the least amount of the most potent antibiotic for that.
Exactly.
So there's a reason that we do that.
Yes.
Dr. Jessie, tell me a little bit about vaccines. I know we've spoken in the past about this. How
Right.
important is it to be vaccinated, especially when we're dealing with the flu season, pneumonia
Yes.
in older patients?
Mhm.
Give me a little idea about what you think of that.
So first thing is we should know what vaccines are. Vaccines are actually defending us, and they help us to boost our own immune system. So there are different types of vaccines, but particularly pertaining to infectious disease. I know Dr. Perel about Alzheimer's and so on.
Those are all
they're trying,
research tools
yes,
that-
research tools. But vaccines are mostly for infectious diseases. And there are different types of infections that we can vaccinate against. There are the bacteria and the viruses, not usually the molds or the yeast. We don't have vaccines for those. But not every infectious disease has a vaccine, unfortunately, not even HIV. So there are certain vaccines that are given from childhood until the age of 18. And there are certain vaccines which are given in particular circumstances, like travel. But the vaccines that you asked about, the influenza vaccine, the pneumonia vaccine, and I would throw in the shingles vaccine as well, these are a little different. Influenza is the most different because that is the only vaccine that is given year after year. And the only reason that is given year after year is because the influenza virus is a very smart virus. It mutates, that means it changes itself year over year. So what you see this year most likely will not be what you see next year. So the vaccine that is produced against the influenza virus for the last year is the one that everybody will be getting this year.
So we're always a little bit behind with that.
We'll
That's
be
why
a
I think-
little bit behind, and that's why sometimes it may not be perfect. Coming to the pneumonia vaccine, anyone actually between the age of 19 to 64 who has certain conditions can be given the pneumonia vaccine. But 65 years on, it is recommended that everybody gets it.
And it helps prevent the most
It
common,
helps
one of the
prevent.
most common or the most common form of pneumonia. So it's very, very important that people take their vaccines in order to try to prevent these infections. You know, it's wonderful to talk about antibiotics, but as Dr. Jessie was mentioning, the idea that certain antibiotics don't work anymore, or that certain bacteria or viruses are mutate and they change because they're smart. They want to exist. Basically, these antibiotics won't work. And then we deal with these super infections that everyone hears about on television, these resistant organisms. And that's why we're coming out with newer and newer antibiotics, but sometimes the
not
organisms...
much in the pipeline.
Not as much as we'd hope. And that's important. But you're
Yes.
right. But it's important to try to do with what we deal with. Couple of things. Let's move on. You mentioned HIV before.
Yes.
And AIDS. People don't talk about AIDS anymore as much as they've done in the past. I trained in the 1990s, and HIV, AIDS was the most cutting-edge process. People were dying in large numbers in front of me. I trained in Manhattan at Columbia, and we were seeing patients every day. It was tragic. And now with the wonderful treatments, and the treatments we've seen so much of an improvement in people's lifestyle. The interesting thing about the treatments is HIV treatments are now on television. I see they talk about retrovirus, which is the name of the virus.
Right.
What's your opinion about these new medicines for AIDS? First of all, do you think there'll be a vaccine for AIDS in the future?
Let's hope. They are actually trying, and there are some in phase 1 trials, but nothing has worked so far. So let's hope that something will work.
So tell us about education for HIV, and the idea, is it a defunct disease? Is it a disease that no longer exists?
It exists, and it's becoming more and more heard of again. So that's a little scary. There was a period where it seemed to be controlled, but it's not so anymore. As you said, years ago in the 1980s, we saw patients who were like gone into AIDS. Like HIV is the first stage. And if the HIV virus has destroyed the immune system of the host to the point where the cell level, we call the CD4 cell level, goes below 200, that is when you call the patient has AIDS. And when that goes below 200, you cannot fight infections. So what we saw then was patients who were like far advanced and dying of many infections. At that time, there weren't good treatments, and patients had to take a whole handful of pills. And who would want to take those day in, day out with a lot of side effects, throwing up, and so many different things to face, and some of them having like big buffalo humps on the back because of, you know, their lipid mechanisms being deranged because of the side effects. But as time progressed, better and better medications are available. Actually, the first 1 pill a day medication was ARRL, and when that came, it was like so good for everyone. Then now we have a lot of 1 pill a day formulations, and there's a lot of choices. But the thing is, the persons with HIV should have the commitment to take their tablets every day. It's a lifelong treatment. It's like diabetes, it's like hypertension. You can't say, I stop my medications because I'm controlled. The moment you take your medications off, the control goes.
So even if there's no detectable virus, they have to continue on the medicine?
They have to continue only because this virus is a sinister virus. It integrates itself, once it gets into the body, it integrates itself into the DNA of the host. So there'll be latent forms sitting inside the body, and the moment you take the medications off, this is going to flare.
And it also makes it communicable so that you can then transfer it to someone else.
Yes.
If you stop taking your medication.
Yes, you may not know that you have the virus, and it's kind of reproducing itself. You may feel good until it's reached the point where it's in the millions. Even if there is a small amount, you're still going to transmit that to someone else.
And Adreana, I'll say it for Dr. Jessie and myself, that was one of the most amazing things in the history of medicine, that we've been able to treat this scourge of AIDS.
Yeah.
That patients are doing well, a vast majority are doing well. Sad to say when we see people who stop taking their medicines because of their personal situations, economic situations, whatever, the idea that those people still sometimes come into our hospital and all the hospitals that I work at, and we see them being devastated. So we still know that that scourge could still be out there.
Yes.
And the idea that we have medicines out there is just really so important.
Yes.
And really has changed it's amazing what medicine sometimes can do.
Yes,
And this is where you can be proud of all the things in the infectious disease world. Let's talk about hepatitis. Hepatitis can go from anywhere where someone went on a trip to Mexico and developed hepatitis A. It's usually self-limiting. There are vaccines for hepatitis A and hepatitis B, which is blood-borne. We see commercials for treatments for hepatitis C. So hepatitis, so you guys are going to give me a primer on hepatitis. Hepatitis means liver, hepa means liver, and liver inflammation. So guys, give me a whole story about hepatitis.
Yeah, sure. So, you know, as you said, you could contract hepatitis, unfortunately, by you know, unfortunately, sometimes if we go away on vacation, let's say, and there's poor hand hygiene as someone is preparing our food, we could be exposed to hepatitis A, which is very scary. And then there's other hepatitis, like hepatitis C, that's, you know, more bloodborne, and we have to be careful for that. And hepatitis B, there's the vaccine, and infants, you know, get vaccinated against the hepatitis B vaccine. And so essentially it is a virus that it affects the liver, but it also could affect, you know, overall, you know, the well-being of a patient.
And people look yellow, they have very different color stool, they're very sick, they feel very fatigued. So there's a lot of symptoms that you get with hepatitis. It's not always a benign process.
No.
So Dr. Jessie, tell me about hepatitis C. I watch television. And all of our people, of our audience watch television too, because they're watching us. So when they see the commercials for all these different hepatitis C treatments, do they work?
Yes, they do work. Actually, in fact, if I am to tell you about hepatitis A, B, and C, these are the common 3 hepatitis that we usually come in contact with. A and B have vaccines. C does not have a vaccine, so it cannot be prevented, but it can be treated. former days in the 1980s and early 1990s, the treatment was very difficult. PEG interferon and ribavirin. That was really terrible for patients to take. And PEG interferon causes so many side effects, one of them being like depression, suicidal ideations, and ribavirin causes depression of the bone marrow, so they have to be monitored extremely closely. And at some point, we felt hopeless, like there's nothing going to come out for hepatitis C. And then all of a sudden, there were new medications coming out, and on the heels of the new medications, newer medications were coming out. And now there are such good medications that you can actually cure it, the hepatitis C, in a matter of 12 to 24 weeks or whatever, according to the guidelines.
That's super. So really another treatment that we've cure almost, and we could say that's scary to say in medicine, because we don't cure many things.
We don't, yes.
High blood pressure has to be treated, diabetes has to be treated. It's very hard to cure patients.
But you have to also bear in mind, you can get it again, so you have to be extremely cautious and protect yourself.
So that's a bloodborne or sexually transmitted
yes, sexually
type
transmitted
disease.
bloodborne, yes.
So mentioning blood, people are always concerned about getting a transfusion. Tell me are there infections in transfusions? Are there viruses, bacteria? Should people be concerned if they have some bleeding issue or need surgery about getting blood?
There is always that risk of having a virus or a bacteria, even for instance a malarial parasite coming into the blood. There's always that possibility. But there are very good systems in place to check and double check and to make sure that there is no pathogen in the blood that is given to patients.
So a vast majority of the time, and Adriana, you do this every day.
Yes.
And we transfuse patients.
Absolutely.
And what about their concerns? What do you tell them about the safety of it?
Of course. I mean, anyone would be concerned. So if we have a sickle cell patient, we have to indicate that on, the blood transfusion sheet. If we have a patient who's undergoing chemotherapy, there's certain blood that is specified for our chemotherapy patients. All blood does get screened for any HIV or, but at the end of the day, as Dr. Jessie said, there is many tests implemented for ensuring that our patients get the safest blood. But we always run a risk, and
There's always a slight risk, but
there's always a slight risk.
I'm going to go rapid fire in the last minute we have. Urinary tract infections. Did we treat them or not?
Okay.
You have a few seconds, Dr. Jessie.
Very common problem. Okay, if you know that it is a urinary tract infection, yes, you do treat it. It is different from colonization of the urinary tract with a bacteria. A colonization you do not treat. So when you say infection, that means the patient has symptoms. It could be complicated or uncomplicated. The simplest form is usually females complaining of burning, lower abdominal pain, and that's a simple cystitis. Primary care physician can treat that. But when it gets complicated, the patient gets fever, chills, flank pain, then it becomes like it's the kidney infection itself. So that requires in-depth workup, especially if they're having fever, chills, altered mental status, they have to go to the hospital and get treated.
And when people have a urinary tract infection, things like yeast infections could occur because of the antibiotics?
Yes, that's a very common problem to get yeast infections.
And there are creams or powders that try to treat that, or we try to do
yes,
different
topicals.
things.
You don't use orals, topicals, yes.
So every part of the body can get infected. And whether it's the head, which is something called meningitis, which we're always concerned about, to the urinary tract, to the skin. And there are different antibiotics for each of those. And I want to thank you guys for really being able to give me all this insight into different antibiotics, into different treatments, and really how far we've come in treating infections. We're not there yet. And hopefully we don't get a resurgence of things, as you mentioned before, but we've come a long way, and really they need to be treated early and aggressively. So thank you.
Thank you. That was okay.